Hi, everyone. Thank you for joining us today for what we hope will be an engaging discussion regarding the opportunities for healthcare investments in Canada. Can I get the next slide, please? Great. Ian and I are delighted to be joined by our friends, Stephen and Andrew from Global Public Affairs. I'll take the next slide, please. So before we get too far into this discussion, I wanted to give an overview of what we plan to talk about. So Ian and I are going to provide a brief overview of how healthcare is currently delivered and funded in Canada in order to set the stage for the rest of today's discussion. We'll then turn to discuss some examples of opportunities for investing in Canadian healthcare. Following that discussion, we're going to turn it over to our friends from Global Public Affairs, who are going to walk us through the politics of Canadian healthcare. And finally, the four of us will engage in the panel discussion, and we'll be happy to take questions from the audience. Please feel free to put your questions into the Q&A function in the Zoom chat. And then once we get there, I'll man the questions. So we'll take the next slide, please. Thank you. And we're going to go one more. One more slide, please. Thank you.
So by way of background for non-Canadian friends attending the webinar, Canada is a federalist state, which means that powers to legislate are divided between multiple levels of government. Here it's between the federal and provincial governments. The federal government has very limited powers in relation to healthcare, so they have a limited ability to regulate healthcare directly. It has authority over marine hospitals, which is not something we're really going to talk about. Criminal law, which is the hook it uses to get into regulation of drugs and medical devices, including approving drugs and medical devices for sale in Canada. It has legislative authority over certain groups, so federal inmates, military, Indigenous groups, and as a result, they're involved in healthcare delivery, including payment for healthcare prescription medications in these groups. And finally, they have what's known as the spending power. So generally speaking, the federal government collects more revenue from taxes, et cetera, than the provincial governments do. And as a result, what they make transfer payments, Sarah's going to talk about this a little bit more on the next slide, but they make transfer payments to the provincial governments. These payments may come with strings attached, which is the case for healthcare payments. Again, Sarah's going to talk about this shortly. The provincial governments are the ones that have power to regulate healthcare directly. The main relevant provision is I'm going to skip over part of this, but the establishment, maintenance, and management of hospitals, asylums, charities, and in the province other than marine hospitals, which are federal. I don't know how many marine hospitals we have in Canada, if any, but so the bulk of healthcare falls to the provinces. So it breaks down into two main areas, which are the funding of healthcare, the establishment of funding done through the establishment and funding of hospitals, as well as payment for other services like primary care with your physicians. And the second is the regulation of how healthcare is provided, including the licensing of healthcare professions. So we'll move on to the next slide.
Thanks. Okay, so let's talk about the Canada Health Act, what it does and what it doesn't do. This is a federal piece of legislation. At a high level, what it does is it sets out the primary objective of Canadian healthcare policy and establishes the criteria and the conditions related to healthcare services that the provinces and territories have to meet in order to receive the full federal cash contribution that Ian introduced, which is called the Canada Health Transfer. So this is an important point, relates back to what Ian said about the division of powers. While the provinces are responsible for the administration of healthcare and funding it at a patient level, the feds are responsible for providing funding to the province. And the way they do that is through this Canada Health Transfer. It's basically the largest major federal transfer of funds to the provinces. And its intention is to support the principles of the Canada Health Act. So in order for a province or territory to receive the full Canada Health Transfer, they have to meet the criteria and conditions set out in the Act. So you'll see them on the slide. Those are the 5 principles. The one that we're going to focus on mostly today is comprehensiveness. This is the criteria that requires that a provincial or territorial health plan ensure all patients for all insured health services. So an insured health service is defined in the Act to mean hospital services, physician services, and surgical dental services that are provided to insured persons. We're going to put aside hospital and we're going to put aside surgical dental. And today we're really going to focus on physician services. So those are defined in the Canada Health Act as any medically required service rendered by a person lawfully entitled to practice medicine. So as it relates to comprehensiveness, the Canada Health Act requires that provinces and territories establish insurance plans that cover all insured services, which include medically necessary services provided by a physician. The Act doesn't define what is a medically necessary service. This has been interpreted by the Supreme Court of Canada to mean, in general, a medical service that is essential to the health and medical treatment of an individual. So decisions about which specific services are covered are ultimately made by the provinces and territories, generally in consultation with the medical profession. And once something is deemed medically necessary, it becomes an insured service. And under the Canada Health Act, the patient cannot be charged for that service when it's performed by a physician. As set out on the slide, the Act also establishes financial consequences for failure to adhere to the criteria and conditions. So remember the Canada Health Transfer. The way the Act is enforced vis-a-vis the provinces and territories is through withholding or even clawing back of these Canada Health transfers. And we've seen these funds been withheld for violations of the Act, primarily in relation to extra billing and user charges. So extra billing is when patients are charged for an insured service, and a user charge is a charge that relates to the provision of an insured service. Generally, if a province or territory allows patients to pay for these things, it's considered to be violating the principle of comprehensiveness under the Act, and the federal government can either withhold funds or claw back funds. There's big Canada Health Act news, really recent. On January 10th, the federal Minister of Health sent a letter to the provinces and territories, and it introduced the Canada Health Act Services Policy. So we're going to talk about this a lot today because it's super new and I wouldn't say exciting, but super new and potentially needle moving. This new policy is aimed at addressing this widespread perceived problem of extra billing and user charges. I'm going to tease this for now, but we're going to come back to it a few times during today's talk. If we can just get the next slide, please. So we just talked about what the Canada Health Act does. On this slide, really high level, what it doesn't do. So just a couple of points to highlight. This act gets a lot of attention as being like the act that regulates healthcare in Canada. And while it's certainly important, especially from a policy perspective, because it establishes a framework, and it's important because it provides sort of the financial do's and don'ts around provincial healthcare, there's a lot it doesn't do. So it doesn't actually regulate the provision of healthcare. It isn't prescriptive. It doesn't dictate what must or must not be covered. And it doesn't really regulate or apply to any entity other than the provinces or the territories. And even then, it doesn't really do so in a very prospective way. It just sort of dictates principles that have to be adhered to. So at a high level, that is the summary of the federal government's involvement in Canadian healthcare. We're going to come back to the Canada Health Act, but before we do, I'm going to turn it over to Ian for an overview of the provincial territorial regulation of healthcare in Canada.
Next slide, please. So as discussed previously, the provinces provide payment for healthcare and they regulate the delivery of healthcare. So we've got the payments on the left here and the delivery on the right. So the provinces have legislation and bureaucracy in place to establish public healthcare plans and fund the delivery of healthcare. So we, as lawyers, we get a lot of questions from clients saying, like, does this violate the Canada Health Act, this thing we want to do? Which, as Sarah said, like, it doesn't apply to anybody other than the provinces. Really, the question is, does it violate provincial legislation that sets up the provision of healthcare? Because often that legislation has penalties for doing things that could risk the transfer payments from the federal government under the Canada Health Act. So in most provinces, there are three main buckets of healthcare funding. There's sort of primary care. At present, in most provinces, it's only funded when delivered by physicians, which, you know, we'll get back to that letter that Sarah talked about, and limited to things that are medically necessary. So they don't pay for things that are relatively clearly not medically necessary, like cosmetic surgeries or sick notes for doctors. But then there are other things that are closer to the line that they don't pay for. So, for example, mental health is generally poorly funded. I'm not going to say unfunded, but it's generally poorly funded. And again, as I mentioned, for primary care, most provinces also have legislative provisions that prohibit anyone from paying for or accepting payment from somebody other than the province, which is a factor for many businesses, because the fees you can charge if you get into public health care are limited to those paid for by the public plans. There's also very limited ability to charge certain ancillary fees. So you can't pay for access to physicians. You can't pay to jump queue, like wait list. As I'm sure our friends are going to talk a little later in the presentation, there's often wait lists to get family physicians in Ontario. The second of the buckets is hospital care. So generally everything that happens in a hospital, with some exceptions, are going to be paid for by the government. So some of the exceptions would be things that aren't medically necessary if you go into a hospital for a surgery, or like payment for private rooms sometimes. And the third bucket is drug coverage. So might be surprising to some of the non-Canadians here, but not all Canadians have prescription medications covered by the public plan. And it varies from province by province who is covered. But all provinces do have a certain degree of public coverage, and the federal government as well, for those three groups I mentioned, the inmates, armed forces, and Indigenous populations. And the provinces have enough drug coverage that they are the biggest payers for prescription drugs in the country. So it's not universal. For example, most people sitting at this table probably don't have any coverage through the provincial plans, but like seniors, low-income individuals tend to have coverage. And the feds have influence on primary care and hospital care. So the first two budget buckets that I mentioned through the Canada Health Act, which Sara discussed. And it's worth mentioning that now they're starting to also have some influence over the third bucket, the prescription drug coverage, through the recently passed Pharmacare Act. Although we're still in the early stages, so we don't know what that's going to look like at the end of the day. Moving over to the other side, the provinces also license healthcare providers and regulate the practice of the professions. In most provinces, this is done through self-regulatory colleges. They're organizations established by law, where the healthcare professionals actually regulate themselves. So it's a bit different from some other countries where the government will regulate. Here it's the healthcare professionals under legislative authority who regulate themselves. We'll talk more about ownership later, but this is also set in provincial legislation. And provincial legislation also impacts delivery in some innovative care models. So, for example, in the case of telemedicine or virtual care, there's rules around whether or not, like if I'm a patient located in Ontario, there are rules around whether or not the physician I see through virtual care has to be licensed in Ontario or not. It ranges from provinces who say yes, they do, to provinces who say as long as the physician is licensed in the location of the physician, it's okay. But caveat emptor, the patient who's receiving the virtual care has to know they can't go to that province's college for disciplinary action. They have to go to the college where the physician's located.
So in light of how healthcare is regulated in Canada, what are the opportunities for investment? Ian and I are going to walk through three types of opportunities. They were on the previous slide. Okay. So the first opportunity we're going to talk about is private delivery of uninsured services. So I spent some time talking about the Canada Health Act and how it mandates that the provinces and territories ensure their healthcare programs fund insured services for all residents, and that insured services are generally those which are medically necessary and provided by a physician. The Canada Health Act does not speak to public coverage of services that are not provided by a physician and or are not medically necessary. It also carves out from public coverage services that are covered under other legislation. So like workmen's compensation legislation, if that provides coverage, then this doesn't fall into this sort of insured, uninsured services bucket. We heard from Ian that provinces and territories are responsible for determining what are insured services within their jurisdiction and for funding those services. There are definitely nuanced differences between the provinces, but in general, insured services are medically necessary, provided by a physician and that are not requested by a third party. So there are carve-outs in most, if not all, of the provincial legislation for a employer or third party requested service, like a diagnostic test or a sick note, as Ian said. Those are generally not considered insured services. And there are certainly businesses operating in Canada that provide those services in a very private and compliant manner. I'm going to take next slide, please. So when we think about insured versus uninsured services, this is where we find some wiggle room and where there's some opportunity for capitalization. So the wiggle room comes from two things. One, what is medically necessary? So for example, preventive medicine, like if you want to just go and do one of those Medcan or Cleveland Clinic, diagnostic test days, a lot of what you're going to get there is considered preventive medicine. And that's something that we're allowed to pay for out of pocket if you want, as opposed to testing for purposes related to a diagnosis or a treatment that is sort of requisitioned by your healthcare provider. Also deemed not medically necessary is, as Ian put it, poorly covered mental health services. And we also have a lot of private clinics that bill the government for insured services, and they also bill patients for uninsured services. The second bucket of wiggle room comes from who's providing the service. So a huge opportunity we've seen in the last 5 to 10 years has been the use of non-physician healthcare professionals to provide healthcare. So remember, the Canada Health Act defines an insured or a medically necessary service as one that is provided by a physician. So healthcare professionals, and in particular nurses, can provide what is essentially private pay healthcare because provincial colleges allow them the same scope of practice as physicians in many respects. And these services, when provided by these other healthcare professionals, are not captured by the Canada Health Act, are not considered to be insured services. And so we get this sort of gray area loophole bucket of sort of freebies. So remember, I mentioned that January 10th correspondence from the Federal Minister of Health making an announcement with far-reaching implications. This is exactly what that's about. So as I said, over the last several years, in the face of concerns regarding access to healthcare, which our friends are going to talk about, a lot of provincial and territorial regulators have expanded the scope of practice for many other regulated healthcare professionals, including in particular nurse practitioners, pharmacists, and midwives. This was done to increase access to care. So in many primary care settings, nurses in particular are performing many tasks that were previously only performed by physicians, including things like diagnosing, treating, and referring patients. So given that these were provided by nurses and given the way that Canada Health Act is drafted, these were not considered to be insured services and could be paid for privately. So this practice, as it sort of grew in scope across all the provinces and territories, attracted a bunch of criticism. Patients really questioning why they were paying for services that they wouldn't be charged for if they were being provided by a physician. So enter this January 10th letter from the Federal Minister of Health to the provinces, in which he introduced the Canada Health Act policy, which requires the provinces and territories to ensure by April 1st, 2026, that coverage of any medically necessary physician equivalent service provided by any regulated healthcare professional be covered under the public plan. So any charges to Canadians for these services, whether provided by a nurse, a pharmacist, or a physician, will be considered extra billing and will be considered user charges, and they will now be deducted from the Canada Health Transfer funding. So we're going to come back to this, talk more about it in our panel discussion. Before turning it back over to Ian to talk about other opportunities, I just want to circle back to a couple more of the opportunities on this slide. We talked about nursing services, but it's worth highlighting that this recently announced policy only appears to address the provision of insured services by nurse practitioners. So there may be some wiggle room, and it does not address the provision of uninsured services, including mental health services that aren't considered insured, including preventive medicine, so private clinics offering preventive medicine, and the rest of the opportunities that Ian's going to now walk us through.
So next slide, please. So regardless of whether or not you're investing in Canada to take advantage of uninsured services and provide private healthcare there, or capitalizing on one of these opportunities to provide services, builds that are built to the public plan. The way that the practice is structured, including ownership, is something that's very important. So we're just going to talk about that right now. So this has been an area of heavy discussion between Sara and I. It's a doctrine that we suspect sort of crept into Canada largely by lawyers working on cross-border transactions with the US. But it's not something that we've seen a ton of enforcement or really any enforcement, some possible exceptions in very specific circumstances. I'll mention them when we get down to the express legislative provisions. So I'm going to talk primarily about physicians during this slide, but it's important to note that the legislative framework is often identical for other healthcare professionals. So this could equally apply to nurses, pharmacists, physiotherapists, dentists, et cetera. So in certain US states, we understand that there's very well-established doctrine known as the corporate practice of medicine that at its most extreme prohibits physicians from practicing medicine while employed by non-physicians or corporations not controlled by physicians. So this could be, like, for example, made of an act of professional misconduct for a physician to do this. In Canada, we don't have laws that go that far. We don't have laws that say physicians can't practice medicine while employed by non-physicians. We do have rules that create these professional corporations. And there's provincial rules around ownership. Generally speaking, all the voting shares must be physician-owned, although there's some variation. So the open question is what constitutes practicing medicine. So only physicians or professional corporations are permitted to practice medicine. But for example, if an employer employs a physician, doesn't restrict any of their activities, maybe not active, doesn't restrict their practice of medicine in any way, like we use them open to their own professional judgment, doesn't try to influence them. Is the corporation actually practicing medicine, or have they hired a physician to practice medicine? So that's sort of an open question. And the conservative and what's become the most common approach has been to structure things similar to what's done in the US, where you set up a professional corp, which employs the physicians, and a separate business services entity that provides sort of all the ancillary care. So like the renting of the space, the front, like the administrative support, buys supplies, things like that. And then you set up some sort of financial arrangement between the two in order to get as much of the profit into the business service entity as possible, which of course doesn't have to be owned by physicians. So very similar to what's commonly done in the US. A few nuances in the regulatory environment when you're setting up that financial relationship. So important to think through the regulatory environment and setting those up. But again, back to my open question, we really only tend to do this with professions like physicians and dentists, and we don't do it with nurses. And I think if you suggested that a nurse couldn't be employed by a company to provide nursing services, most people would be like, that's ridiculous. But for example, in Ontario, both nurses and physicians are governed by the same piece of legislation. It's not identically worded legislation. It's the same law called the Regulated Health Professions Act. So if we can't do it for a physician, in theory, we shouldn't be able to do it for a nurse. So all this to say, there's a lot of gray area. The conservative approach, like I said, which is the most common, is to set up this PC and business service entity corporation, similar to what's in the US, but a lot of room for discussion. And then before we move on, just want to touch briefly on some places where there are express legislative provisions. So as I mentioned, we've seen a tiny bit of enforcement in provinces where professions have regulations on fee splitting. So a professional can't split the fee charged for professional service with a non-professional. So you really have to think about, if you do this, set up your professional corporation business service entity, you really have to think about, like, am I splitting professional fees? And there has been a case involving dentists in one province relating to that. And then there are express legislative provisions on ownership. The main one that jumps to mind is ownership of pharmacies. So in Ontario, very restrictive. Pharmacy has to be owned by 50% plus one pharmacist, unless there are, of course, loopholes like anything. And BC has some restrictions as well, not on ownership, but on directorship and things like that. So we can go to the next slide. I'm not going to spend too long on the next slide because I realize time is passing quickly. But we're starting to see some very interesting technological innovations and investment in technology that either provide great opportunities or, interesting to us, the lawyers, are things that our legal system's not very well set up to deal with. And we have had government regulators even admit they're not sure how to regulate some of these things. So for example, if a piece of software or a piece of hardware, something like that, starts doing things traditionally done by a regulated health professional, like, for example, if it reads a patient's chart and comes up with a diagnosis, that's kind of the practice of medicine. We would expect that to be regulated as a medical device. But should the colleges be involved? Like, it's practicing medicine in the province. So a lot of uncertainty. But in addition to the uncertainty, there's great opportunities in Canada because of some unique challenges here. So for example, technologies that aid in the remote delivery of healthcare are great because we have, sitting straw, there might not be a physician there. So it's great if you've got some sort of video technology that integrates well with blood pressure cuffs and, all that stuff. So great opportunities for that in Canada.